Hello everyone, this is Dr. Deptee Warikoo, Department of Physiotherapy, Dolphin PG Institute of Biomedical and Natural Sciences, Dehradun. I welcome you all to today's lecture. The topic of today's lecture is elbow evaluation. So first, let us talk about elbow. What is elbow and what are the articulations? The elbow is a joint. The articulations are made up of ulnohumeral joint and the radiohumeral joint. The articulating surfaces on the anterior aspect of the distal humerus are the hourglass-shaped trochlea and the spherical capitulum. These structures are situated between the medial and lateral humeral epicondyles. The trochlea forms a part of humero-ulnar articulation. A groove called the trochlear groove spirals obliquely around the trochlea and divides it into medial and lateral portions. Then we also have a indentation in the humerus located just above the trochlea, which is called the coronoid fossa. The capitulum, like the trochlea, lies anterior to the shaft of the humerus. A groove called the capitulotrochlear groove separates the capitulum from the trochlea. The indentation located on the humerus just above the capitulum is the radial fossa. If we go posteriorly, the distal humerus has indentation by a deep fossa called as olecranon fossa. So now we know that humeral articulations, the humero-ulnar joint is a modified hinge joint. I told you medially it has an hourglass shaped trochlea. It faces anteriorly and downwards around 45 degrees from the shaft of the humerus. The concave trochlear fossa, as I already explained, on the proximal ulna faces upwards and anteriorly 45 degrees from the shaft of ulna. The primary motion of this joint is the flexion and extension that occurs at elbow joint. These are the basic positions of ulnohumeral or the ulnotrochlear joint. The resting position of this joint is 70 degrees elbow flexion and 10 degrees supination. The closed back position is extension with supination. And the capsular pattern for ulnohumeral joint is flexion and extension both. The next joint is the humeroradial joint. The humeroradial joint is again a hinge pivot joint. The laterally placed spherical capitulum, as described earlier at the distal end of the humerus, is convex, and the concave bony partner is the head of the radius. The movements mainly occurring are supination, pronation, and flexion and extension. If we talk about the positions of this joint, the resting position is full extension or full supination. Closed back position is elbow flexed to 90 degrees and forearm supinated to 5 degrees. The capsular pattern is flexion and extension. Next joint which comes in this complex is proximal or the superior radio-ulnar articulation. It is within the capsule of the elbow joint but works as a distinct articulation. Here, the convex rim of the radial head articulates with the concave radial notch on the ulna. There is a ligament called annular ligament which encircles the rim of the radial head. It is very important and stabilizes the head of the radius against the ulna. The primary motion of proximal radio-ulnar joint is pronation and supination. If we talk about the positions of this joint, the resting position is 35 degrees supination, 70 degrees elbow flexion. Closed back position for superior radioulnar joint is 5 degrees supination. And the capsular pattern is equal limitation of supination and pronation. Now here you could see the ligaments of the elbow joint. I had already explained in my previous lectures about the capsule, the importance of the capsule and the ligaments. Now here you could see the medial ulnar collateral ligament. It is considered to be the major soft tissue restraint of valgus stress at the medial aspect of the elbow. The lateral or the radial collateral ligament complex includes the lateral collateral ligament, the lateral ulnar collateral ligament, and the annular ligament. It is a fan shaped structure that extends from the inferior aspect of the lateral epicondyle to the humerus and attached to the annular ligaments. And it is a very important ligament as well. Here you could see the lateral collateral ligament, what I told you, the annular ligament, and the accessory collateral ligaments. Now we come to the assessment of the patient. So first we will start off with the subjective assessment. Subjective assessment, the first thing what we have to see is the age of the patient. Age is very important. Few conditions are very common in early ages and few like arthritis are seen in later ages. Next, we have to see the mechanism of injury. In the case of traumatic events, the mechanism of injury helps to guide the diagnosis. For atraumatic injuries, specific symptoms can be highly useful in determining a diagnosis. Then we have to see the time. When are the patient's reports symptoms? When does he reports the symptom? How long is the symptom there? Does the condition come or go? The pain come or go? Is there any aggravating factor or any relieving factors? The pain history is very important. As I always tell that we have to make sure that we take the pain history in very proper manner, like the site of pain, then the pattern of pain, the area of pain, the onset of pain, aggravating factors, relieving factors, then severity of pain and irritability of pain. One more thing which we have to consider here is the pain radiating or non radiating? Are there any aggravating or relieving factors? Then presence of numbness or tingling is very important. We have to ask the patient about it. And then if there is any deformity, bruising, wasting, or any muscle spasm, as the patient tells us. We also have to take the medical history, the what medications patient is on, the past medical history, or if the patient has brought any diagnostic testing or imaging along with him. Then observation. Observation is very important. Observation may we have to see the carrying angle. In males, as already told in the previous class, the carrying angle is 5 to 10 degrees, and in females it is 10 to 15 degrees. If the carrying angle is more than 15 degrees, the condition is called as cubitus valgus, and if it is less than 5 to 10 degrees, it is called as cubitus varus. Here you could see a varus deformity with a gun stock deformity in the left arm of the patient here. I hope it is properly visible. Then you have to see if there is any swelling around the elbow. The reason for swelling around the elbow is mainly found to be because of if there is any ligamentous injury. It could be radial collateral ligament or ulnar collateral ligament. If there is any ligamentous injury, then we have to see, or if there is any bursitis. Even bursitis could show some swelling. That is olecranon bursitis. Olecranon bursitis or student's elbow as it is called may also show swelling of the elbow. There, before palpation, you have to ask few questions to the patient that could guide you to diagnosis. Like, do your symptoms change with the movement of your shoulder or wrist? Does your elbow ever slip out or feel unstable? Does the pain change with gripping activities? Do you ever experience numbness or tingling? Was the elbow hyper extended during the time of injury? Do you relate the symptoms to a throwing activity or increased during the, like, few patients who are having hobbies like tennis, golf? Is that aggravating your pains? These things has to be taken before going into palpation. You have to make sure that environmental and personal factors are taken into account. Then we go for palpation. So we have to palpate majorly the humerus, the radius, and the ulna. We start off with humerus. Palpate the medial epicondyle, that is the bony protrusion of the distal humerus that comes on the medial aspect of the arm. Then the lateral epicondyle, that is the bony protrusion that comes on the lateral aspect of the arm. Go beyond on the posterior part, palpate the olecranon part and see if there is any pain or tenderness during extension while the palpation is going on. Then go and palpate the head of the radius, palpate the olecranon process as well. These are the few structures which we have to look into palpations: the lateral epicondyle, the medial epicondyle, the olecranon fossa, the olecranon process. This you can see the diagrammatic representation of the anatomy of elbow joint. Then we have to palpate the soft tissues. It is very important to see if there is tenderness in the soft tissues. So the muscles which we need to palpate are the biceps brachii, which could be palpated in flexion, triceps in extension, the brachioradialis, keep the elbow flexed and thumbs up, that is the mid prone position. Then the wrist flexors, the wrist extensors, and brachialis when you do an elbow flexion with pronation. Then go for ligamentous palpations. Palpate the ulnar collateral ligament. Start from the uh, uh, medial epicondyle and keep palpating down. Then the radial collateral ligament, the annular ligaments. Check if there is any tingling sensation while you give a tap on the uh, posterior to the medial epicondyle to see ulnar nerve integrity and then see the radial nerve integrity. Then we go for joint examination. The joint examination could be done like posterior joint examination, the lateral joint examination, anteriorly and medially. Posteriorly, the olecranon is palpated. We have to check if there are any spurs or there is any fracture of the olecranon or some loose bodies are present over there. Along with that, we also palpate the triceps. Then we go to the lateral joint examination, that is, we palpate the radiocapitular joint. We see if there are if there is presence of any osteophytes over there or if there is any joint effusion. While we palpate, if the patient shows tenderness, or we have to grade that tenderness, what grade of tenderness patient is showing to rule out about the effusion. Then go towards the anterior joint examination. You have to see, like, anterior capsulitis will produce poorly localized tenderness that can be identified easily with a palpation. Then also palpate your muscular tendons like biceps and brachialis. If there is any partial tears while you palpate the muscles, patient will show second to third grade of tenderness. Then we go for medial joint examination. Medial joint examination, we could see the inflammation of the ulnar nerve. It could be easily identified, as I already told you. Just do a tapping or a tinal examination over the posterior aspect of the medial epicondyle. So by this, you can also palpate ulnar nerve in the cubital tunnel. After the palpation is completed and you have ruled out what you have expected that could be there, the next step what we follow are to check the active movements of the elbow. Now, when we check the active movements of the elbow, we check it on the both sides. As I have already told you in the examination part, never go directly to the affected part. You have to check the unaffected part as well, so that you could rule out if there is any discrepancy or not. So we start off with active movements. Check the flexion of the elbow, which could be 140 to 150 degrees. Extension, then supination of the forearm, that could be up to 90 degrees. Pronation of the forearm, again 80 to 90 degrees. If you think that combined movements are necessary, that you could check the combined movements of the elbow along with your shoulder movements as well as your wrist movements. See, this is a diagrammatic representation of the flexion extension of the elbow. This is the supination and pronation. In mid prone position, the hand is kept, and then supination and pronation is checked. Elbow is in flexed position. These movements will be checked with the help of goniometer. You could use any goniometer, universal goniometer, bubble goniometer, gravity held goniometer, inclinometer, whatever you want and whatever is available. Then passive movements will be checked. While checking the passive movements, you also have to see the end feel. For example, when you do an elbow flexion in a passive movement, the end feel is basically tissue approximation. For elbow extension, as the olecranon gets jammed with the humerus, the end feel will be bone to bone end feel. Then the forearm supination, there would be tissue stretch. Same for forearm pronation. This is what we have to see in passive movements. Then you could go for resisted isometric movements to see the power of the muscles working around the elbow. Muscle flexion power around the elbow has to be greatest in the range of 90 degrees to 110 degrees with the forearm supinated. At around 45 till 135 degrees, flexion power is only 75 degrees of maximum. About this, I have already told in my biomechanics lecture that how these things work. Then you have to check the resisted isometric movements of supination, pronation, elbow flexion extension, then also the wrist flexion and extension. The muscles which are working around the elbow basically are the flexors of the elbow are brachialis, biceps brachii, brachioradialis, pronata teres, flexor carpi ulnaris. So the nerves which we are focusing are musculocutaneous, radial, median and ulnar nerve. Then extension of the elbow is basically done by triceps and anconeus. Supination of the forearm is done by supinator and biceps brachii. Here the posterior interosseous nerve and the musculocutaneous nerve is mainly working. Pronation of the forearm, the quadratus pronata quadratus, pronata teres and flexor carpi radialis. Flexion of the wrist with flexor carpi radialis, flexor carpi ulnaris. Extension of the wrist, extensor carpi radialis longus, extensor carpi radialis brevis and extensor carpi ulnaris. So basically all the nerves could be checked when you do a resisted movements checking of the elbow joint. This is, you can see how the examiner is checking the resisted movements of the elbow. All the movements, this is flexion, extension along the wrist also is checked. Then we go to functional assessment of the elbow joint. Functional assessment is very important because here we will identify whether our patient is able to perform the ADLs independently or he is in need of a supervision or is totally dependent on the help of a person. We can use many different type of scales like DASH, quick DASH, patient specific functional scale or patients related elbow evaluation American Shoulder and Elbow Society Evaluation, ASES. These tests could be easily used. We could also use P4 4-item pain intensity measure or SF36 forms to identify the functional assessment of the patient. You have to check whether the patient is able to bring the hand to mouth while lifting the weight, that is, check proper elbow flexion. Push the arm straight, that is to check elbow extension. Here we will identify whether the patient is able to do it functionally or he is fairly doing it functionally, he is poorly doing it functionally, or he is at all non functional. It will depend on the repetitions he is able to perform these activities and the weight he is able to lift. For elbow flexion, the weight will be major category, and for elbow extension, repetitions will be major category. For example, if we tell the patient to perform to lift the weight, if he is able to lift 2.7 kgs according to the body weight, it will depend, then we could say that patient is functionally fit. Repetitions, if he is able to perform 5 to 6 repetitions, he is functionally fit. For supination of the arm, tell the patient to open the door starting with the palm down. Again, check the repetitions. If 6 repetitions are okay, then he is functionally fit. For pronation, tell the patient to open the door starting with the palm up. Again, for the repetitions, same thing will be considered. Normal range of elbow flexion, as I already told you, is approximately 0 to 145 degrees. However, if he is able to perform 130 degrees, we will say he will be functionally somewhat equal to perform activities. Pronation and supination ranges are 75 to 85 degrees, but most activities are done within 50 degrees of each motion. So, if the patient is able to achieve these, then he is able to perform the activities. Next, after the functional evaluation, check the nerves. See, the nerves are very important factor over the elbow. If the median nerve is damaged, then the muscles like pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis, flexor pollicis longus, pronator quadratus, and the two lumbricals, lateral two lumbricals won't be working. They will have a motor loss. So the patient will be having a very weak or lost pronation. The wrist flexion will be very weak along with abduction. Radial deviation at the wrist will be totally lost. Thumb will be working very weakly in abduction. The grip will be decreased, or in median nerve injury, you could also see the patient with an ape hand deformity. If the anterior interosseous nerve is damaged, again the flexor pollicis longus, flexor digitorum profundus, pronator quadratus, thenar eminence, and lateral two lumbricals will be having motor loss. Patient will have a weak pronation, weak opposition and flexion of thumb, and weak finger flexions. Patient will be having a very difficulty in pinch or tip to tip gripping. If ulnar nerve is damaged, then there will be motor loss in flexor carpi ulnaris, medial half of the flexor digitorum profundus, palmaris brevis, hypothenar eminences will be lost, adductor pollicis will be having a motor loss, medial two lumbricals, and all the introsize. Here the patient will have deformity. In ulnar nerve, we see claw hand deformity. There will be loss of thumb adduction, inability to extend the second and third phalanges. There will be loss of abduction and adduction of the fingers, loss of distal flexion of the little finger, loss of ulnar deviation at the wrist, and weak wrist flexion. Some sensory losses could be also seen here. If the radial nerve is damaged, encorneus, brachioradialis, extensor carpi radialis longus, extensor digitorum, extensor pollicis longus brevis, abductor pollicis longus, extensor carpi ulnaris, extensor indicis, and extensor digiti minimi will have a motor loss. Again, the patient will be having loss of supination, loss of wrist extension leading to wrist drop. inability to grasp objects, inability to stabilize the wrist, loss of finger extension, and inability to abduct the thumb. Then posterior interosseous nerve, which is a branch of radial nerve, will again show you weak wrist extension, weak finger extensions, difficulty to grasp, leading to the motor loss of the muscles like extensor carpi radialis brevis, extensor digitorum, extensor pollicis longus and brevis, abductor pollicis longus, extensor carpi ulnaris, extensor indicis, and extensor digiti minimi. Then we move to some special tests over the elbow. So, main special tests are, we have to check the ligamentous instability, then lateral epicondylitis test, elbow flexion test, that is the test for ulnar nerve, and pinch grip testing. Before the tests, check for the flags. The flags, you have to see whether there are red flags which are due to infection or inflammation, malignancies, fracture, or any abnormal vital signs. If there are any yellow flags, that could be due to psychosocial factors, passive coping, fear avoidance beliefs. So check everything and then go for the tests. So we have to see if there is a green flag, then only for physical examination is allowed, or if there is a yellow flag. So we have to see about the flags and then start off with the tests. So the ligamentous tests are ligamentous instability test. This is the test designed to test for the varus and valgus instability in the elbow. Here the patient will be in a sitting position with elbow slightly flexed up to 20 to 30 degrees, and the patient will stabilize with the hand, and adduction or varus force is applied by the examiner to the distal forearm of the patient. Here we test the lateral collateral ligament to check the varus instability while you keep on palpating the ligament. Now the examiner feels the ligament, gives the stress if there is excessive laxity when doing the test or a soft end feel is felt, that indicates the injury to the ligament. An abduction or valgus force at the distal forearm is then applied in similar fashion to check the medial collateral ligament and check if there is any valgus instability. Here you could see the therapist is checking for valgus and varus instability. Then the first test, which is importantly done for the lateral epicondylitis, is called as Cousin's test. This is the first method to check the lateral epicondylitis. The patient will be in a sitting position, the therapist standing in front of the patient. Then the patient's elbow is stabilized by the examiner's thumb, and the examiner's thumb rests on the patient's lateral epicondyle. Patient is then asked to make a fist and then pronate the forearm and radially deviate and extend the wrist. While the patient is doing this, the wrist is held by the therapist and the examiner resists the wrist motion. A positive sign is indicated by a sudden and severe pain in the area of the lateral epicondyle of the humerus, which depicts that there could be presence of lateral epicondylitis. The second test to evaluate lateral epicondylitis is called as Mills maneuver or Mills test. Again, the patient is in sitting position. While palpating the lateral epicondyle, the examiner here passively pronates the patient's forearm, then flexes the wrist fully and extends the elbow. While the examiner does this test passively, a positive test is indicated by pain over the lateral epicondyle of the humerus. Then the test for medial epicondylitis or the golfer's elbow. Again, the patient is in sitting position and the examiner stands in front of the patient. While the examiner palpates the patient's medial epicondyle with his thumb, the patient's forearm is passively supinated and the elbow and wrist are extended by the examiner. A positive sign is indicated by pain over the medial epicondyle of the humerus, depicting the presence of golfer's elbow. Then there are tests for joint dysfunction. To test the radiohumeral joint, the examiner positions the elbow joint at the position of the pain and then radially deviates the wrist. This is to compress the radial head along the humerus. The production of pain, if any, would always suggest a positive test for the, the dysfunction of the radiohumeral joint. To test the ulnar humeral joint, the examiner again positions the elbow at the position of the discomfort and then causes a compression. Any dysfunction or discomfort will depict the dysfunction of ulnohumeral joint. Then we could also do some neurological tests like Wartenberg's sign. The patient sits with his or her hands resting on the table. The examiner then passively spreads the fingers apart, then asks the patients to bring them back. If the patient is unable to squeeze the little finger, this is a positive test for ulnar neuropathy. Then you could also check for Pronata-Tiri syndrome. Here the patient with the elbow flexed up to 90 degrees will be in a sitting position. The examiner strongly resists the pronation as the elbow is gradually extended. A positive test is indicated by a tingling sensation or the presence of paresthesia in the distribution of the medial nerve along the forearm and the hand. Then the Tinel sign, as already I told you, the area posterior to the medial epicondyle will be tapped. A positive sign is indicated by a tingling sensation along the distribution of the ulnar nerve. It could be up to hand also, giving the presence of ulnar neuropathy. Then you could also perform pinch grip test. The patient is asked to pinch the tips of the index finger and thumb together. Normally there should be tip to tip pinch. If the patient is unable to perform tip to tip pinch but does a pulp to pulp pinch of the index finger and thumb, this is indicative of positive sign of anterior interosseous nerve injury. Then we also check for the muscle lengths. We have to test the biceps length. The patient is placed in supine position with shoulders to be tested off the edge of the bed. The shoulder is then passively extended to the end range and the elbow also extended. Normally what happens? Elbow extension should be same as that seen with the active movement. But if the biceps are tight, we won't be able to perform full elbow extension. To test triceps length, the patient is placed in sitting position. The examiner passively forward flexes the arm to full elevation while the elbow is in extension. The elbow is then passively flexed. Normally the elbow flexion should be similar, but here if there is any tightness, it will be restricted. With this, you have to check about the restrictions of the lengths of the muscles. See, the first one is to check the biceps and the second one is to check the triceps. To test the length of the long flexors, wrist flexors and wrist extensors, for the wrist extensors, the patient is placed in supine lying with elbow extended. The examiner passively flexes the fingers and then flexes the wrist. You could see this movement won't be possible if there is tightness of the wrist extensors. This is the second movement where you keep the patient in the same position and try to perform the extension of the wrist. If the wrist extension is fully not available, that means there is tightness of the long wrist flexors. Then also check the dermatomal levels along the elbow. You have to check along the elbow the C5 region. Here you could see the C5 region, the C6 region which crosses the elbow, the C7 region. So these are the three basic nerve roots which you have to check. It is very important to accomplish the elbow evaluation with dermatomal evaluation as well. You could also do the neurodynamic tests. For median nerve, you have to check upper limb neurodynamic test 1, the radial nerve upper limb neurodynamic test 2B, the ulnar nerve The upper limb neurodynamic test 3, that is ULTT1, ULTT2B, and ULTT3. This is the anterior aspect and posterior aspect of the sensory distribution around the elbow. This we have to check about the sensory distribution as well. There could be some referral pain patterns also in the elbow. For example, the biceps could also refer pain over the anterior elbow, the brachialis over the anterior arm, and the lateral thenar eminence. Triceps could also have a referral pattern to posterior shoulder, arm, elbow, medial epicondyle. Then brachioradialis could have it over the lateral epicondyle, the space between the thumb and the index finger. And corneus could have it over the lateral epicondyle area, supinator over the lateral epicondyle and posterior web spaces. Pronata teres over the anterior forearm, extensor carpi ulnaris over the medial wrist, extensor carpi radialis over the posterior forearm to posterior wrist, extensor carpi radialis longus over the lateral epicondyle and posterior lateral wrist, extensor indicis over the posterior forearm to appropriate digit, whichever tendon of the extensor indicis is affected. Then palmaris longus, anterior forearm to palm, flexor digitorum superficialis, palm to appropriate digit, flexor carpi ulnaris, anterior medial wrist, flexor carpi radialis, anterior medial wrist. Then you also have to check if the patient has bring along with him the plain film radiography. Here you could see the differences. First, you could see easily the dislocation. In the second one, you could see the joint dysfunction. While the radiography, patient could also come along with his arthrography or some MRIs, so that you could rule out the affected soft tissue structures or some CT scan. Then, with all these evaluation process, you have to fill in the elbow evaluation form. Once the elbow evaluation form is filled, which contains the pain evaluation, the movement evaluation, the strength evaluation, then the functional evaluation, the patient's response, and the various scales which you are using to evaluate the patient, you will come to the conclusion of about the condition that could be there. With the help of elbow evaluation, you could diagnose with which condition patient has come to you. To make a proper diagnosis, an evaluation should be very proper and very elaborate. If a proper diagnosis is done, then only you could do a proper treatment and you can make a proper treatment plan as tailored as per the patient. So this was about the elbow evaluation. I hope you all could understand it. If there are any queries, I welcome all the queries. You could join me or you could drop out your messages, your queries. I would answer them. Thank you so much. Thank you so much for today's lecture.